Dr. Robert Hammond had spent 15 years as chief trauma surgeon at Memorial Medical Center in Houston, Texas. He'd completed his residency at Johns Hopkins, trained in advanced trauma life support, and handled some of the most complex emergency cases in one of America's busiest Level 1 trauma centers. His surgical team operated with military precision. When Dr. Hammond called for an instrument, he expected it in his hand within seconds. When he gave orders, he expected immediate compliance without question. He ran his operating room with the authority of someone who'd earned his position through years of grueling training and thousands of successful surgeries. The new night shift nurse in his trauma unit was May Santos, who'd transferred from a hospital in Manila 6 months earlier. May had her Texas nursing license, solid references, and spoke excellent English, but Dr. Hammond barely acknowledged her during their first shift together. To him, she was just another nurse, someone to follow his orders, hand him instruments, and stay out of his way while he did the actual life-saving work. During a routine trauma case car accident victim with internal bleeding, Dr. Hammond barked orders while May assisted. Clamp, suction, retractor. May responded efficiently, but when Dr. Hammond prepared to ligate a vessel, May quietly said, "Doctor, the bleeding might be coming from..." Dr. Hammond cut her off without looking up from the surgical field. "I can see where the bleeding is coming from. Just hand me what I ask for." May fell silent, but she'd noticed something in the patient's anatomy that suggested a secondary bleed Dr. Hammond hadn't identified yet. She was right 10 minutes later, when the primary repair was complete. Bleeding continued from exactly where May had tried to warn him. Dr. Hammond spent another 20 minutes locating and repairing the secondary source. Frustrated at the complication, he never acknowledged that May had tried to alert him. To him, nurses were assistants, not diagnosticians. They weren't trained to make those kinds of clinical observations. That was what years of medical school and surgical residency were for. What Dr. Hammond didn't know was that May had worked in Manila's busiest trauma center for 8 years before coming to Texas. She'd assisted in thousands of emergency surgeries in a facility that handled everything from vehicle accidents to industrial injuries to violence-related trauma. Philippine trauma centers often operated with fewer resources than American hospitals, which meant nurses had to be more observant, more resourceful, more capable of anticipating complications before they became critical. May had learned to read surgical situations the way experienced nurses do, understanding anatomy, recognizing bleeding patterns, anticipating what the surgeon would need before they asked for it. She wasn't just a nurse, she was an experienced trauma nurse with clinical judgment developed through years in high-pressure emergency medicine. But Dr. Hammond saw her as a recently arrived Filipino nurse who should be grateful to work in an American hospital and should follow his orders without offering input. Over the following weeks, this dynamic continued. May would notice potential complications or recognize signs of developing problems, and Dr. Hammond would dismiss her observations without consideration. "I need you to follow protocols, not diagnose patients," he told her. After she suggested a patient showing subtle signs might be developing compartment syndrome, she was right, but Dr. Hammond didn't appreciate her interference. His attitude wasn't overtly hostile, just condescending. He treated May the way he treated all nurses, as competent assistants who shouldn't overstep their role by trying to make clinical judgments that were the surgeon's responsibility. Then came the night that changed everything. It was 2 a.m. when ambulances brought in victims from a major highway pile up multiple vehicles, several critical patients arriving simultaneously. The trauma center activated mass casualty protocols. Dr. Hammond was handling the most critical case, a young man with massive chest trauma, probable cardiac injury, bleeding heavily. 2 other surgeons were in adjacent operating rooms with their own critical patients. Every trauma surgeon in the hospital was occupied. May was assigned to Dr. Hammond's OR, along with another nurse and an anesthesiologist. The patient was crashing, blood pressure dropping, heart rhythm unstable. Dr. Hammond opened the chest, found the cardiac injury, a laceration to the right ventricle, began the delicate repair, while the patient received massive transfusions to replace blood loss. It was extremely complex surgery under the worst circumstances. Dr. Hammond worked with intense focus, repairing the heart injury while calling for instruments, sutures, additional units of blood. May anticipated his needs, maintaining the rapid pace he required. But she was also monitoring the patient holistically, watching the anesthesiologist's readouts, observing the surgical field, tracking blood loss and transfusion volumes. 30 minutes into the surgery, with the cardiac repair partially complete, May noticed something. The patient's blood pressure wasn't responding to transfusions the way it should. The central venous pressure was dropping. She glanced at the surgical field and saw what Dr. Hammond, focused intently on the heart repair, hadn't yet noticed: blood accumulating in the upper abdomen, visible at the edge of the operative field. Dr. May said calmly but urgently, "I think there's abdominal bleeding. The CVP is dropping, and there's blood tracking superiorly from the abdomen." Dr. Hammond was in the middle of placing a crucial suture on the heart. "The bleeding is from the cardiac injury. I'm repairing it now. Keep the transfusion running." But May had seen enough trauma cases to recognize the pattern. "Doctor, the cardiac injury is anterior. This blood is coming from posterior, from the abdomen. The patient might have a liver laceration or splenic injury we haven't identified. If we don't address it, he'll bleed out even after the heart is repaired." Dr. Hammond was about to dismiss her again. He could see the cardiac injury. He was repairing it. That was the obvious source of hemorrhage. But something in May's tone made him pause. She wasn't being dramatic or insistent. She was stating a clinical observation with the calm certainty of someone who'd seen this pattern before. And the patient's pressure asterisk wasn't asterisk responding to the massive transfusion despite the cardiac repair being nearly complete. Dr. Hammond made a split-second decision. "Extend the incision. Let's visualize the upper abdomen." The other nurse extended the operative field exposure. Blood welled up from the abdomen. May was right. There was a grade for liver laceration that had been missed in the initial assessment, hemorrhaging severely. If they'd closed after the cardiac repair without addressing it, the patient would have died from intra-abdominal bleeding. Dr. Hammond immediately began managing the liver injury while continuing to stabilize the heart repair. It turned the surgery into an even more complex operation: simultaneous cardiac and hepatic trauma repair. But because May had identified it when she did, before the patient had lost too much additional blood, they could address it. The surgery lasted for more hours. Dr. Hammond repaired the liver laceration, completed the cardiac repair, controlled all bleeding sources, and finally closed while the patient received over 30 units of blood products. When they finished, the patient was critically ill but stable. He'd survived injuries that would have been fatal if the abdominal hemorrhage hadn't been identified when it was. In the OR afterwards, while the nurses cleaned up and prepared for the next case, Dr. Hammond stood quietly for a moment, then looked at May. "You saved that patient's life," he said. "I was so focused on the cardiac injury that I missed the abdominal bleeding. If you hadn't recognized it and insisted I look, he would have bled out in the ICU after we closed. I would have thought we'd done everything right, and I would have lost him." May nodded acknowledgement, but didn't say anything. Dr. Hammond continued, "How did you know? How did you see that when I didn't?" May chose her words carefully. "Doctor, in Manila, at Philippine General Hospital Trauma Center, we see everything: vehicle accidents, construction injuries, violence cases. We operate with limited resources compared to here. We have fewer CT scanners. Sometimes we can't get all the imaging we'd like before surgery. So nurses learn to be very observant during operations. We learn to watch for patterns, how blood behaves, how pressure responds, what different types of bleeding look like. I've assisted in maybe 3,000 trauma surgeries. I've seen abdominal hemorrhage present this way many times. The pattern of blood tracking, the CVP dropping despite transfusion, these signs together suggest intra-abdominal source. I didn't diagnose you did that when you visualized it. I just recognized a pattern I'd seen before and brought it to your attention." Dr. Hammond was silent for a moment. "I treated you like you were just a nurse, like your role was to hand me instruments and follow orders. But you were making clinical observations at a level that surgeons make them. You saw something I missed because you have more experience with this specific type of trauma presentation than I do." He looked at her directly. "I'm sorry. I dismissed your input multiple times because I assumed nurses don't have the training or experience to make those kinds of clinical judgments. But you do. You have 8 years in one of Asia's busiest trauma centers. You've probably seen case volumes and complexity I haven't encountered. I was wrong to treat your observations as interference rather than valuable clinical input from an experienced trauma professional." May appreciated his acknowledgement. "Dr. Hammond, I'm not trying to overstep. You're the surgeon, you make the decisions. But in Filipino nursing culture, especially in trauma centers, we're taught that everyone on the team, surgeons, nurses, anesthesiologists, everyone contributes observations. The surgeon has final authority, but the best outcomes happen when everyone feels free to speak up if they notice something. I've seen too many cases where someone noticed a problem but didn't say anything because they thought it wasn't their place, and the patient suffered. So I was trained to speak up, respectfully, when I observed something that might matter. Not to challenge your authority, but to give you information you might not have from your vantage point. Dr. Hammond nodded slowly. That makes sense. That's how teams should function. But I've been trained in a more hierarchical system. The surgeon is in charge. Others follow orders. It's efficient, but it also means I might miss input from team members who have valuable perspective. He paused. That patient is alive, because you spoke up even after I'd dismissed you before. That took courage, and it took clinical judgment that saved a life. Over the following weeks, Dr. Hammond's approach changed. He started actually listening when May made observations. He asked her opinion during complex cases. He introduced her to other surgeons as May Santos, one of our most experienced trauma nurses. She trained in Manila. She's seen everything. He began treating her not as just a nurse, but as an experienced trauma professional whose clinical judgment had been earned through years of high-pressure emergency medicine. Other nurses noticed the change. May became known in the trauma unit as someone the surgeons actually listened to, whose observations were valued. Dr. Hammond started implementing more collaborative team practices in his OR, explicitly asking nurses and other team members if they noticed anything concerning, creating an environment where everyone felt they could speak up without being dismissed. The patient May had helped save the young man with cardiac and hepatic injuries, recovered after weeks in intensive care. When Dr. Hammond spoke with the family, he told them honestly, "Your son is alive because we have excellent nurses." May Santos identified bleeding I'd missed. She saved his life. 6 months later, Dr. Hammond was invited to speak at a trauma surgery conference about team dynamics in the OR. He told the story how he'd dismissed a Filipino nurse's clinical observations multiple times because he assumed nurses weren't qualified to make those judgments, and how that same nurse had saved a patient's life by recognizing a pattern he'd missed. "I had 15 years as a trauma surgeon," he told the conference audience. "I'd trained at top programs, handled thousands of cases, but I'd also developed blind spots. I assumed that clinical judgment was something only physicians possessed, that nurses were assistants rather than partners in patient care." May Santos, who'd worked 8 years in Manila's trauma center, had clinical experience with certain trauma patterns that exceeded mine, but I couldn't see that because I was too busy seeing her as just a nurse rather than as an experienced trauma professional. He continued, "Filipino nurses make up a significant percentage of nursing staff in American hospitals, especially in critical care and trauma. Many of them trained in facilities that handle extraordinary case volumes with limited resources, which develops clinical skills and judgment that are incredibly valuable. But how many of us actually recognize and utilize that expertise? How many of us dismiss their input because we assume American-trained physicians are automatically more knowledgeable?" That night in my OR, a patient would have died if I'd continued that assumption. Instead, he lived because one nurse had the courage to speak up and the clinical judgment to recognize what I'd missed. Today, Dr. Hammond runs training sessions for new surgical residents about team dynamics in the OR. He uses May's case as a teaching example how hierarchical thinking can create dangerous blind spots, and how the best surgical outcomes come from teams where everyone's clinical observations are valued regardless of their role or where they trained. May continues working trauma at Memorial Medical Center, now recognized not as just a nurse but as one of the unit's most experienced trauma professionals. Her clinical insights are sought out by surgeons who've learned that years of experience in Manila's high-volume trauma center developed skills that save lives in Houston, and Dr. Hammond keeps a note in his locker. Written after that mass casualty night, "The nurse I called just a nurse saw what I couldn't see, said what I didn't want to hear, and saved a life I would have lost." Excellence in medicine isn't about hierarchy or credentials. It's about recognizing clinical judgment wherever it comes from and creating teams where everyone can speak up when they see something that matters. Filipino nurses aren't just nurses. They're experienced healthcare professionals whose training and judgment deserve the same respect I expect for my own. The surgeon who dismissed May Santos as just a nurse learned that some of the most valuable clinical judgment in American hospitals comes from Filipino nurses who trained in facilities where resource limitations demanded extraordinary skill, and where just a nurse meant someone who could recognize life-threatening complications that even experienced American surgeons might miss not through luck, but through years of trauma experience that taught them to see patterns, trust their observations, and speak up even when hierarchical systems suggested they should stay silent.